Hello and welcome to the Mohit Show. Today I will be reading the WPATH files executive summary and excerpts from it. To begin, the WPATH files pseudoscientific surgical and hormonal experiments on children, adolescents, and vulnerable adults. The World Professional Association for Transgender Health, WPATH, enjoys a reputation of being the leading scientific and medical organization devoted to transgender healthcare. WPATH is globally recognized as being at the forefront of gender medicine. However, our report shows the opposite is true. Newly leaked files from WPATH's internal messaging forum, as well as a leaked internal panel discussion, demonstrate that the world-leading transgender healthcare group is neither scientific nor advocating for ethical medical care. These internal communications reveal that WPATH advocates for arbitrary medical practices, including hormonal and surgical experimentation on minors and vulnerable adults. While there is a place in medicine for risky experiments, these can only be justified if there's a reliable, objective diagnosis, no other treatment options are available, and the outcome for a patient or patient group is dire. However, contrary to WPATH's claims, the best available evidence suggests that gender medicine does not fall into this category. Risky experiments can also only be justified when patients give true informed consent. Yet the leaked messages in our report reveal that WPATH-affiliated doctors are knowingly violating bedrock principles of medical ethics and informed consent. Our report will prove that WPATH is promoting unethical medical experiments on children, and that WPATH members are fully aware that children and adolescents cannot comprehend the lifelong consequences of gender-affirming care. As such, our report will prove that WPATH is promoting unethical medical experiments on children, adolescents, and vulnerable adults. The report will show that, as is revealed by its own internal communications, WPATH does not meet the standards of evidence-based medicine, and members frequently discuss improvising treatments as they go along. Our report will further show that members are fully aware that children and adolescents cannot comprehend the lifelong consequences of gender-affirming care, and in some cases, due to poor health literacy, neither can their parents. In the WPATH files, members demonstrate a lack of consideration for long-term patient outcomes despite being aware of the debilitating and potentially fatal side effects of cross-sex hormones and other treatments. There is also evidence that patients with severe mental health issues, such as schizophrenia and dissociative identity disorder, are being allowed to consent to life-altering hormonal and surgical interventions without members making any attempt to first address these underlying issues. Moreover, the files provide evidence of how far off the rails this experiment has gone, with discussions about surgeons performing non-binary surgeries to create types that do not exist in nature. These extreme body modifications desires are framed as medically necessary healthcare, even though the surgeries do not meet the definition of being experimental. The files also show that autonomy, a bioethical concept that was once a shield to protect patients from being experimented on against their will by doctors, is now being used by WPATH members as a sword. In its name, there is nothing a doctor can deny a patient seeking hormonal and surgical interventions. The contents of the WPATH files are of utmost importance because WPATH has broken the chain of trust in gender medicine. Trust in professional training grounded in robust scientific evidence is crucial for doctors, who face time constraints that prevent exhaustive investigation of every treatment protocol. Influential organizations such as the American Academy of Pediatrics and the Endocrine Society rely on WPATH's standards of care when developing policy and practice guidelines for the treatment of gender dysphoria. Similarly, parents and vulnerable patients depend on clinicians influenced by WPATH. The truth about WPATH, as revealed in the files, is therefore essential for patients, including the parents of trans-identified minors, to make informed decisions about their medical treatment. And now moving on to the excerpts. And just a note, the links to all of this will be in the description of this video. WPATH files excerpts, exposing the realities of gender medicine. Preface. WPATH and gender clinicians and activist groups more generally insist that gender medicine is settled science. They present puberty blockers, cross-sex hormones, and genital surgeries as evidence-based, life-saving care and suicide prevention. Rachel Levine, the U.S. Assistant Secretary for Health, claims there is no argument among medical professionals, pediatricians, pediatric endocrinologists, adolescent medicine physicians, adolescent psychiatrists, psychologists, etc., about the value and the importance of gender-affirming care. But when gender clinicians and lobbyists think no one else is listening, what they say can be quite different and quite shocking. They 1. Make clear they give cross-sex hormones and surgeries to people with limited or no capacity to consent, including people with major mental illnesses and minors. 2. Acknowledge that minors do not understand the long-term consequences of gender affirmation, including sterility. 3. Discuss extreme body modification surgeries, such as the removal of genital organs entirely or creating a neo-vagina alongside a penis, with no medical justification. 4. Frame detransition and post-treatment regret as trivial. 5. Claim that minors should be given life-changing hormones and surgeries because otherwise they will kill themselves, despite no evidence that such interventions make suicide rarer. 6. Describe serious side effects, including fatal ones, and common suboptimal outcomes. All the quotes come from WPATH members in posts on the WPATH Members Forum or during internal panel discussions. The full materials will be made available to journalists, and I also have the full report in the description of this video. An unethical approach to consent among adults with comorbidities. Patients with dissociative identity disorder are regarded as having the capacity to consent to hormones. One client who had dissociative identity disorder, we worked on all alters giving consent to HRT before it was started. They had alters who were both male and female gender, and it was imperative to get all the alters who would be affected by HRT to be aware and consent to the changes. Ethically, if you do not get consent from all alters, you have not really received consent, and you would be sued later if they decide HRT or surgery was not in their best interest. This is from a gender therapist. So are patients with severe mental health issues. In reply to a nurse practitioner who is struggling with how to handle a patient with PTSD, major depressive disorder, observed dissociations, and schizoid typical traits who wishes to go on hormone therapy, I'm missing why you are perplexed. The mere presence of psychiatric illness should not block a person's ability to start hormones if they have persistent gender dysphoria, capacity to consent, and the benefits of starting hormones outweigh the risks. So why the internal struggle as to the right thing to do? This is by Dr. Dan Karasik, lead author of the WPATH Standards of Care 8 Mental Health chapter. Mentally ill and homeless people are regarded as suitable for referring for genital surgery. I have also intervened on behalf of people who have been diagnosed with major depressive disorder, PTSD, homelessness, and got at least an orchiectomy. In the last 15 years, I had to regrettably decline writing only one letter, mainly because the person evaluated was in active psychosis and hallucinated during the assessment session. Other than that, nothing. Everyone got their assessment letter, insurance approval, and they are living, presumably, happily ever after. This is by a gender therapist. There's a lack of concern regarding young people regretting sacrificing their fertility. Some of the Dutch researchers gave some data about young adults who had transitioned and had reproductive regret, and it's there, and I don't think any of that surprises us. This is by Dr. Daniel Metzger, a Canadian endocrinologist. Minors offered life-changing interventions they cannot fully understand. Concerning whether is it reasonable to expect children and young adolescents to grasp the effects of gender-affirming care. It is out of their developmental range to understand the extent to which some of these medical interventions are impacting them. They'll say they understand. But then they'll say something else that makes you think, oh, they didn't really understand that they're going to have facial hair. This is from Diane Berg, child psychologist and co-author of the Child chapter of WPATH Standards of Care 8. We're often explaining these sorts of things to people who haven't even had biology in high school yet. This is from Dr. Daniel Metzger, Canadian endocrinologist. Dr. Christine McGinn, American plastic surgeon, reported performing about 20 vaginoplasties on patients under 18 over a 17-year period and confessed that not all had perfect outcomes. On the complexity of discussing fertility preservation with children and adolescents during an internal panel discussion, it's always a good theory that you'll talk about fertility preservation with a 14-year-old, but I know I'm talking to a blank wall. They'd be like, ew, kids, babies, gross. I think now that I follow a lot of kids into their mid-20s, I'm like, oh, the dog isn't doing it for you, is it? They're like, no, I just found this wonderful partner and now want kids. So I think, it doesn't surprise me. Most of the kids are nowhere in any kind of brain space to really talk about fertility preservation in a serious way. All this by Dr. Daniel Metzger, Canadian endocrinologist. Extreme body modifications with no medical justification. I've performed mastectomies without nipples, or have created chests with varying degrees of remaining breast tissue, or created incision patterns specific to my patient's wishes. For bottom surgery, I've performed minimal depth vaginoplasties, vulvoplasties, phallus-preserving vaginoplasties, and nullification procedures. I'm quite comfortable tailoring my operations to serve the needs of each patient. This is from Dr. Thomas Satterwhite, a Californian surgeon. How do we come up with appropriate standards for non-binary patients? What best practices and standards are you following in your experience? I found more and more patients recently requesting non-standard procedures such as top surgery without nipples, nullification, and phallus-preserving vaginoplasty. Also by Dr. Thomas Satterwhite. Gender clinicians should provide care for trans people whose embodiment goals do not fit dominant expectations, such as those who want mastectomies without nipples, mastectomies for people who do not want breasts from estrogen, and vagina-preserving phalloplasties. This is by an activist law professor. I think we're going to see a wave of non-binary affirming requests for surgery that will include non-standard procedures. I've worked with clients who identify as non-binary, agender, and eunuchs, who have wanted atypical surgical procedures, many of which either don't exist in nature or represent the first of their kind, and therefore probably have few examples of best practices. This is from a doctor. Detransition and suicide prevention. In a reply to a post about a detransition study, acknowledgement that detransition exists, even to a minor extent, is considered off-limits for many in our community. This is by WPATH President Marcy Bowers. Individuals are entitled to make their own mistakes, and while medical systems and professionals can and should help them avoid mistakes, the power dynamic between a gender specialist and their patients, and between cis and trans people more generally, means that some mistakes are valued higher than others. This is by a researcher. What is problematic is the idea of detransitioning, as it frames being cisgender as a default and reinforces transness as a pathology. It makes more sense to frame gender as something that can shift over time, and to figure out ways to support people making the choices they want to make in the moment, with the understanding that feelings around decisions may change over time. In reply, in reply to a therapist concerned about a 13-year-old non-binary natal female with an eating disorder who is requesting testosterone, a pediatric endocrinologist recommended the child be living as the other sex for 6 to 12 months and have at least one supportive patient. She added, "It's very difficult to ask that they wait until 16 because by then they will be dealing with menstrual periods and complete breast development. Waiting appears to increase the risk of suicide attempts." Serious side effects and common post-surgical complications. An exchange between two doctors about the severe, potentially fatal side effects of testosterone use in natal females. Testosterone is a known carcinogen. 16-year-old female patient found to have two liver masses, hepatic adenomas, 11 by 11 centimeters and 7 by 7 centimeters, and the oncologist and surgeon both have indicated the likely offending agents are the hormones. We are prepared to support the patient in any way we can, for example, top surgery when medically stable, etc. This is by a doctor. I have one transition friend slash colleague who, after about 8 to 10 years of testosterone, developed hepatocarcinoma. To my best knowledge, it was linked to his hormone treatment. It was so advanced that he opted for palliative care and died a couple months later. Speaking of a young patient who developed pelvic inflammatory disease after 3 years of testosterone, has atrophy with the persistent yellow discharge we often see as a result, nurse practitioner, and describing young natal females developing pelvic floor dysfunction and even pain with orgasm by a doctor. I used to have bleeding after penetrative sex. It would hurt to have an orgasm. My uterus atrophied also. Trans-identified female emergency medical technician, a paramedic. Natal male patients on estrogen are described experiencing erections feeling like a broken glass from a registered nurse. Poor outcomes are accepted as a fact of life. It would be great if every patient could be perfectly cleared prior to every surgical intervention, but at the end of the day, it's a risk-benefit decision. If the patient can't follow the dilation schedule, they may lose depth, but as long as they're capable of making that decision of sound mind while informed of the risks, then that may be all you can do. This is from a doctor. And that covers the excerpts provided by the WPATH files. You can see additional files available on the website linked in the description. And if you are interested, I can do a reading of the full WPATH files report, though that will be a very interesting 242 pages for me to read. I'll do it though. Anyways, make sure you all have a good day, and this is Mohit signing off. Bye.